thank you for the invitation. Victor, thank you for inviting me, and Carlo as well. And of course, Professor Regli for being the chair of this wonderful symposium we have here. It is a true honor to be part of your symposium, especially the first one. And I don't know how I got invited because I know so little about machine learning. I'm really here to learn more than I am to give out knowledge, but nevertheless, here I am. I was given the task of talking about virtual and augmented reality in skull-based surgery. This is obviously a huge topic, and I would try to focus it on certain aspects of it to keep within the 30 minutes. My disclosure is that I am a consultant for surgical theater that makes the equipment for this augmented and virtual reality. I am very interested in the fact that my piece is called the Intermezzo. So for all the musicians in the audience, obviously this means intermission. So I'm kind of like the halftime show. I'm kind of like J-Lo and Shakira at the Super Bowl. So this talk is aimed to be entertaining, and it's perfectly appropriate to be the intermezzo here. This is going to be a lighter topic than a lot of the topics that you have been part of. So let's define virtual reality. Virtual reality in a very simplistic way is just simply turning ordinary CT scans and MRI scans in two-dimension black and white into colorful three-dimensional objects that can be manipulated, rotated, reset, altered, interacted with in three-dimension in full color. And this has really revolutionized my practice in many ways. The early going is very, very simple thing. You turn the ordinary two-dimensional angiograms and MRAs and whatnot into three-dimensional objects that you can tour around and look at the anatomy and whatnot. We have gone very, very far from that initial offering to all these aspects now in neurosurgery, including practicing operations, the so-called rehearsal. Patient engagement, of course, is the consent process, as well as anatomical teaching to trainees, medical students, as well as residents and other trainees. And finally, the surgical navigation and really operating with so-called X-ray vision now with augmented reality. I'm not going to be able to talk about all these topics, and so we're going to talk a little bit about the clinical applications, but focus a lot actually today on morphometric anatomical investigations that may be more applicable for the wider audience today. So from touring the anatomy, we've come a long way to interacting with the anatomy and practicing operations. For example, here's a tumor in the deep of the skull base in the pineal region, and we are altering the anatomy in virtual reality space to test out this approach. The first approach is a interhemispheric approach. We can see that just by doing this, that the corpus callosum is in the way. This is not a very good approach. The veins are covering the tumor. Again, let's try something else. The supracerebellar approach infratentorially, this dissection is somewhat challenging in real life because of the reach, but you can see that in virtual reality, we can practice it and then prove to ourselves that this angle of the tentorium is challenging. Look at my neck. It's really hard to see that looking upwards. So we're now practicing the third variant, which is a paramedian variant to the supracerebellar approach. And it turns out that this is much easier to reach the tumor in a much more ergonomic way for the surgeon. And so this rehearsal data gave us this information that we can use to choose the approach for this particular patient. Again, these are patient-specific anatomical renderings in 3 dimensions that we can use for practicing. And that led to this paper here. Coupled with augmented reality now, for surgical rehearsals has other uses. One of the big criticism when this first came out is, hey, for experienced surgeons, this is useless. This is only for trainees. Not so true, because there are approaches that we, even as experienced surgeons, don't do very often. For example, this one. We are now coupling surgical rehearsal with augmented reality, meaning that we're going to inject segmented anatomy into the operative field through the microscope to help us guide these difficult and challenging approaches that we practice. So here's an example of the lateral transorbital approach for a tumor, a very seldomly done approach, that would require rehearsal even for experienced surgeons. So here is a tumor that's right behind the eye that one can say, oh, well, we can do a transorbital approach. But the transorbital approach is a somewhat new approach and not very well established. So let's practicing in virtual reality. We put a burr hole to access both the orbit as well as the anterior cranial fossa, take out the lateral orbital rim here, make the cuts all in virtual reality, make the bone flap disappear, boop, and then we drill down the sphenoid wing, both the lesser sphenoid wing and the greater sphenoid wing, and we prove to ourselves that, wow, this actually has a wide exposure to this, despite the fact that we're operating through the orbit. So for rare approach, there you go. So now I'm going to take this file as an electronic file to the operating room as an augmented reality template. This is done through the transpalpebral approach. We're dissecting here the eyelid so that we can get to the lateral orbital rim and part of the frontal bone. This is a minimally invasive route so that there are no big scars and big incisions to heal on the patient's head. And it is a very tried and trustworthy way. Let's jump to the, there's a bone flap walk. Now, here it is, the augmented reality template that we had generated in virtual reality rehearsal in the office, injected into the operating microscope and navigated by a tracked microscope with that navigation machine. So this tells me how much bone I need to remove as I move on with this operation. So let's take that off and start drilling. We are now drilling just as we did in the office. We're now taking off the sphenoid wing, both lesser and greater wing, opening the dura of the anterior temporal tip. And with any luck, the tumor should be right there, and it is. The exposure is plenty, even though we're operating through the orbit. There's the cyst at the back of the tumor. The tumor is therefore all removed now. That's the end result of the surgery cosmetically, and there it is, end result of it radiographically. So there's the tumor disappear, and that yellow is where all the bone that we removed during surgery, and so it's very little bit, and the eye should be just fine. So rehearsal is also useful for rarely done approaches. So with augmented reality now tracked by navigation, integrated by navigation, we can now approach the Goldilocks principle of skull-base surgery, meaning that we can be very minimally invasive, but the size and the location of the opening, the minimally invasive keyhole opening, is perfectly placed so that we can get the job safely done. Here's an example of how that is used. This is the burr hole craniotomy for microvascular decompression. We're doing it through a tiny, tiny hole, and this is only possible really when you have navigation integrated with the augmented reality. We are drilling that perfect opening in the office, and we're taking that template right here into the operating room, and through a navigation tracked microscope, injecting the augmented reality template onto the patient already positioned, and drawing that template opening onto the patient's exact anatomy. And then again, opening the skin, and then once again, tracking that anatomy once again on the bone. So here is that injected with the bone exposed now. We know that our opening is going to be absolutely the same as the one that we practice in the office, and in the perfect position to get this job done. And of course, not to belabor the point, we get the job done, the microvascular decompression goes perfectly fine. And so for experienced surgeons, this tool can be used not to make it any better per se, but to make it smaller, more efficient, etc. So here's the next example I want to show you of a clinoid meningioma out and demonstrating the concept of operating inside the skull out. And this is, of course, only doable not in real life, but in virtual reality. So here's a tumor that we want to take out. And we are going to do that through, let's look at it in rehearsal first. There's the tumor, perfectly situated right above the clinoid. The anatomy is perfectly clear in 3 dimensions, and now we can practice it. We can practice several openings. We end up choosing not to do this particular one. We end up choosing this one. And for the mini terional, we can operate inside out. We put the burr hole exactly in the position that we want to drill the sphenoid wing, in the exact position that optimizes the operation. Put a marker there, drill the template that we will use in the operating room. Okay, this is the opening that perfectly placed, perfectly sized for the operation. We're practicing, doing the anterior clinoidectomy in rehearsal. And then what we can then do is take this template into the operating room, and through a navigation integrated microscope, project the template onto the patient who's already positioned. And there you have it. That template is projected onto the patient so that we know that the opening is exactly where we practice it. We're tracing that template onto the patient's scalp. You can see the hair underneath. There it is. And that allows you to plan the incision. So the incision, we don't plan the incision on down. We plan the craniotomy on out. This is the concept of operating inside outwards to make sure that the operation goes exactly the way it should. And again, not to belabor the point, the anterior clinoidectomy goes very smoothly because we've already practiced this. We're simply duplicating something that we know works in the office, and the tumor comes out very nicely. And you can see how minimally invasive that incision is, which is planned inside outwards. So here's well, what about monitor-based navigation? Why not keep with this? The problem with monitor-based navigation for me is that it is tracking a three-dimensional object on the 2 dimensions, and also that you have to look away from the field. Superman operates with X-ray vision. He doesn't need to look at a monitor and turn his neck, look at the monitor for the X-ray vision. He sees through the wall for the X-ray vision. And so augmented reality then allows us to do that. The example to demonstrate this to you is the anterior putrescectomy. The middle fossa floor has a lot of things hidden under it. It has the labyrinth, the cochlea, the facial nerve and vestibular cochlear nerve, as well as the carotid artery. All of that all those are potential traps for us as we drill through that petrous apex. Now, if we segment all that anatomy and project that into our operative field, then we can literally drill and operate with X-ray vision. So here's the rehearsal for that. We put markers on the floor and to demarcate where we need to drill. And we also can fade the opacity of the bone to show us the hidden objects inside the bone so that we don't drill into them. And then we practice this in a rehearsal so that we can avoid the labyrinth, the cochlea, and so on and so forth. And then when real life comes, we can project all those same parameters as augmented reality overlay objects into the operative field through a navigation track microscope. And there's absolutely no way you're going to drill into the no-fly zones with this as protection. So again, the blue is the cochlea. The yellow wall in the back there is the plane of the 7th 8th nerve complex. And this shows you exactly where you need to drill. You've already practiced it. And this allows you to literally, almost literally, do the operation with X-ray vision, just like Superman does. So that led to this, these sort of things. So now I want to focus on a topic that may be applicable for the wider audience here. And that is how we can use this not only for teaching, for navigation, for clinical use, but also for morphometric anatomical research and what that holds for the future. There's several advantages of using VR over cadavers to do these anatomical research. And then we'll go through these one by one as I show you the examples. You have unlimited specimens, especially for normal specimen, and you can drive your p-value with that, power your study with that. The same platform, which is the VR platform, allows you to do the experiments and get data in the same platform. There's no need to do the operations on the cadaver and then take the cadaver to the CT scan and back and to measure things. These specimens that you do in VR have a reset button. So if you're doing comparing 2 approaches that have overlapping bony removals, you can do that in the same specimen because you have that reset button. And finally, the VR advantage is that it allows you actually to use disease specimens as your substrate for the experiments, something that you obviously cannot do with cadavers. How would you find a cadaver with a petroclival meningioma to then do experiments on and measure the data? So my first example is this one, which we are very proud of, and I think Dr. Matheson is still on the call, and this was published in ACTA a couple of years ago. We were interested in doing pineal surgery, of pineal biopsies at least, through the Foramen of Monro, and asking the question whether it should be done with one burr hole versus two. And then we discovered that there was very little information known about the Foramen of Monro. And then we discovered that the VR is a perfect tool to look at the Foramen of Monro, because these 3D objects are imminently maneuverable, so that you can look down the barrel of the Foramen of Monro and do measurements. So here it is. The background is that we want to biopsy this pineal tumor with or without hydrocephalus. And then this is the operation that we would do. Like we would do a third ventriculostomy first to divert the CSF. And then we finally do the biopsy of the pineal tumor. But should we do this with one burr hole? Should we do it two burr holes? If we do it with one burr hole, how much traction do we put on the fornix? Can we hurt it by doing that? So the Foramen of Monro cadaveric studies are very hard to do because it is empty space, and fixation artifact can really limit your accuracy. And in live subjects, if you want to study the Foramen of Monro, it really poses a problem, because we do scans in axial, coronal, and sagittal planes. Where is the foramen? Is the foramen here? Is the foramen there? On the sagittal plane, where is this thing? So with virtual reality, there's absolutely no question what the foramen looks like. But here's a dive into the ventricle, just show you the view in the VR. And you can dive through the Foramen of Monro just like CSF would flow through it, and you can look down the barrel of the foramen, even though that foramen is not in particular sagittal, coronal, or an axial plane per se. And during the measurements, we can do it in all the planes, both in the negative situation where this, or you can do it in the positive. This is almost like pouring wax into the ventricle and then measuring the wax model of how wide or small or how big the foramen is, so that we really can trust this data, because we do this in the negative, we do it in the positive, we do it in all the angles that assures that the most accurate measurement in the axis of the Foramen of Monro has been taken. And with that, we reported our data. The data itself is not the point of this particular talk. We did 15 subjects in each sex, and then we had 60 of them, and show that the data, that it turns out the Foramen of Monro is bigger in males than female, and on the left side more than right side. No one knew that before. This is all brand new finding. And the Monro is shaped like a nuclear funnel. All that, again, is belaboring the point of this. This is just to show you that this study methodology is doable in VR, much more, I believe, trustworthy than the cadaver or in radiographic models. So again, the data is not that particularly exciting. And then, okay, so part two. Part two is actually dealing with the hydrocephalic subjects with pineal tumors. What we did here was that we chose the study path. So there's one path that is the ideal path to doing the third ventriculostomy. The next path is the ideal path to do a biopsy. We then bisected this distance and call this the study entry for the one burr hole technique. If we use one burr hole to do both jobs, the third ventriculostomy as well as the biopsy, then we use that study entry point to project two probes into the virtual head, one for the third ventriculostomy, one for the biopsy. And then we measured the display of those 2 points, 2 probes at the Foramen of Monro to therefore calculate and understand how much of the traction on the fornix one is placing when you do that. And it is as high as 7.2, 5.6, with the average of 5.76. So it goes to show you that it is perhaps possible in some patients, but up to half of the patients, you're really putting a significant amount of traction on the fornix if you do this always through one burr hole. So the one burrow technique should be limitedly applied. And we again thank Dr. Matheson for choosing us for the cover for that particular issue. Next benefit of using VR to do these experiments, it simplifies the experiment because it simplifies the platform for both experiment and measurement taking. What we did here was we progressively removed the occipital condyle to understand how that widens my surgical corridor. Does that widen the surgical corridor in a hyperbolic way or in a linear way? As you progressively remove more and more occipital condyle, which of course is not a good idea in real life. So in the cadaver, what you would have to do is do it in the lab, drill out, do the measurements in a navigation system, coupled with a CT scan, go back to the laboratory, drill out some more, repeat the CT scan and registration and navigation to get data, and back and forth. It is extremely cumbersome. So we discovered that by removing the condyle, there is a linear expansion of that corridor, and all of this, both the alteration of the anatomy as well as the measurements, are all done in a single platform in VR. Powering the statistics is another benefit of using VR to do these kinds of research. I am not, with all due respect with the Italian group, this is not to point out a problem. This is just to show that it's very common in this sort of research to have a very small n number. They used 3 heads and did 6 sides to report this data. We did a similar study and used 6D sides, 30 heads, 6D sides, so 10 times the statistical power in doing this measurement of how it widens, how a orbitotomy widens your angle to the tuberculum sellae as well as to the ACOM complex in this variation of a supraorbital keyhole. So it turns out that even though in each individual head, taking the orbitotomy opens up the angle to the ACOM complex very little, when you drive it with 60 heads, it actually becomes statistically significant, even though for each head there was only increased very little. So again, it changes the whole statistical analysis ball game when you can use large number of specimens, which obviously is not possible with cadavers. The reset button, this is a big one. This is a big one because it allows you to use one particular specimen to measure several openings. And this is recently published in this. So what we're doing here is that we're progressively, again, enlarging the supraorbital keyhole with or without, so without the osteotomy, with the osteotomy of the orbit, and with a full drilling of the sphenoid wing. And the reason why this cannot be done in cadavers, when you compare this with the mini-pterional or the lateral transorbital approach, is that by the time you reach D here, you are removing bone that you would also remove for the mini-pterional. So obviously, you cannot use the same specimen to measure both approaches and compare, because you're actually running into each other when you do the experiment. With VR, there is no such problem. You can simply reset the bone, and then you can use the same anatomy, the same specimen to compare those approaches and do a pair student t-test. These are paired because you're doing the same specimen to do both approaches to get some statistical analysis. So the reset button, critical. My final point about the advantage of using VR for this kind of research is the pathology. Again, cadavers are normal. They don't usually have meningiomas or whatnot. And even if they do, how are you going to find 60 of them to do comparisons? So cadavers have no pathology. Patient's not going to let you do 2 operations just for the sake of measuring data and measuring the degree of freedom and whatnot. So why not use clinical data and transform that into laboratory specimens? Now you can use that laboratory specimen to compare approaches that may or may not overlap with each other and so on. So this was recently completed with a petroclival model. So these are models of petroclival meningiomas that our collaborators from Beijing Tiantan Hospital shipped to us through HIPAA-compliant means. And we segmented the tumor into zone 1 and zone 2. Now, what we did here was this. we took those models and performed several approaches to see how much tumor was blinded by either bone or the brainstem. We considered the bone as blinding a structure and the brainstem also as an immobile blinding structure. So as you can see for this particular tumor, the retrosigmoid opening generated some blind spots. Okay, you can't see it, obviously. Now you go inside the skull and now you can show yourself the blind spots. So once you're inside the skull, you can see the blind spots. Now, obviously, you will need an endoscope with high angles to see these sort of openings, these blind spots with this approach. All right. So in the same specimen, the disease specimen, we're doing a retrolabyrinthine approach. And we're now testing how much tumor is blinded by that approach. And voila, there is nothing blinded on the brainstem side, but there is quite a bit blinded by the labyrinth on the bone side, on the clival side, or the dura side. And then you can augment this retrolabyrinthine approach with the anterior putrescectomy and others with the translabyrinthine approach to, again, measure the blind spots. So this is not the blind spot one. This graph shows you the amount of surgical freedom that each of these approach generates for each tumor. So the retrosigmoid approach, the surgical freedom to the ipsilateral petroclival fissure, middle of the clivus, basilar artery, et cetera, et cetera. This shows you, if you just look at it on a gross scale, that the retrosigmoid approach actually gives you a lot of freedom to all this, to this region. And the next one is the blinded tumor volume. Again, these are the tumor volumes that are blinded to you by these approaches compared in the same specimen. And you can see that the highest blinded volumes in the retrosigmoid approach. So the retrosigmoid approach as a standalone approach is really not very good. The retrolabyrinthine approach, sorry. The retrosigmoid approach has some blind spots. Now, why are these striped and why are these solid? The solid side is the blinded tumor volume on the clival side, and the stripe is the blinded volume on the brainstem side. So this graph tells you, and it's, I think, the first time this question has been answered by a quantitative way, that the retrosigmoid approach, the weakness is that the brainstem is hiding tumor from you. With all these so-called transpetrosal approach, the weakness is that the bone is hiding tumor from you. It's hiding from the bone side versus the brainstem side. So now logic dictates that we really should be considering combining the retrolabyrinthine and retrosigmoid approach, because then neither the brainstem or the bone is going to blind volumes from you. So this combination is perhaps the most sensible one and not the combined, so-called combined, different argument for a different day. Now, pursuant to the current symposium with machine learning, what all this shows is that we can teach, in the future, I don't need to be the one making these measurements. We can teach the computer to do these various approaches, retrosigmoid, retrolabyrinthine, and whatnot. We can teach the computer and produce algorithms such that the computer itself can measure the surgical freedom in the areas thereof. You can see how, by the way, in this, you can see how it's a little bit cumbersome measuring the freedom areas. Here it is. You have to do this. Well, the machine can do that. And if we can have algorithms that allows the machine to do the opening as well as the measurements, then the machine can actually suggest to us, hey, for this particular tumor, if the goal is for total removal, then perhaps this approach A and approach B may be the best. So, if we can teach the EKG machine how to interpret EKG, we can at some point be able to teach the machine how to make these openings and make these measurements such that the AR slash artificial intelligence machine is going to be able to suggest a opening and an approach to these tumors that will be the most benefit for the patients. So to end my talk, and I have left plenty of time, hopefully, for questions. My goal was to skip over the clinical stuff pretty quickly to talk about the morphometric research stuff. But all of this will be hopefully gathered under one roof in this special virtual reality, augmented reality issue of Neurosurgical Focus, which is coming out in August 2021. And I am the lead topic editor, and I am here begging all of those folks who are in the field to please submit their papers for this particular issue, so to make it as robust as possible. As Tristan mentioned, I am all over the internet. I guess there are, in fact, people who do track what I say, which is a good thing. I welcome collaborations in any direction, and of course comments and so on.